Hi friends, in this video we shall be discussing about two very important topics which are compartment syndrome and crush syndrome. So first let's begin our discussion with compartment syndrome. What is compartment syndrome? It is increased pressure, right? Increased pressure is an orofacial compartment to a level that compromises microvascular perfusion. There are a lot of causes of compartment syndrome, but the most common cause being the fracture, which is seen in around 70% of cases. Other causes include soft tissue contusion, burns third degree, bleeding disorder, post ischemic swellings, tight cast dressing, or extravasation of IV infusion. So, let's understand the pathophysiology of the compartment syndrome. So, the increased tissue pressure. Now, this raises the question, what is the increased tissue pressure over here? So, basically, it is an absolute pressure which is more than 30 mm of Hg, or we talk about the diastolic minus the compartment pressure, which should be less than or equal to 30 mm of Hg, and this is generally taken as the threshold pressure level. So when there's this increased tissue pressure, what happens is that there is reduced microperfusion, right? Now what happens because of this reduced microperfusion is that the cells are not going to get oxygen, right? As a result of which there is going to be tissue ischemia, right, and cellular anoxia, which is eventually going to cause the irreversible muscle damage, right? So an absolute pressure greater than more than 30 mm of Hg, or a compartmental pressure difference of diastolic minus compartmental pressure of less than 30 is usually considered as a threshold pressure. Now because of this increased tissue pressure, there would be a reduced microperfusion. This reduced microperfusion is eventually going to cause cellular anoxia and tissue ischemia, resulting in irreversible muscle damage. So, how would such patients present to you? The most common symptom presenting to you would be pain out of proportion, right? So if you have attended your clinical wards, or if you would be attending your clinical wards, you might come across scenarios where a patient has undergone a close reduction of a fracture and you are an evening resident or a trainee on ground, where you go and assess the patient and you find that the pain is out of proportion. Then there is pain on passive stretch, right? So these are two very important early signs that you see in cases of compartment syndrome, right? And other signs which include paralysis, paresthesia, and pallor. But remember that these are late sign. So please do not wait for the development of pallor to diagnose a compartment syndrome, or be it a pulselessness, right? A pulselessness, because remember, it is an extremely late sign, right? So by the time you would be waiting for a pulselessness to be developed, it would be too late. So please do not wait for pulselessness to develop. It would be generally presenting with pain out of proportion, pain on passive stretch. Then you have your late signs, which include paralysis, paresthesia, and pallor, and an extremely late sign, which is pulselessness, right? Now there's one important thing, that you would always have this idea in your with you, that the compartment syndrome is usually only associated with closed fractures and closed wounds. No, please remember that it can also occur with the open wound, right, injury, if the wound does not extend into the affected compartment, Right. The purpose of mentioning this over here is that you might be getting a true or false, or which of the following is true of it, regarding compartment syndrome, where a statement might be given to you that compartment syndrome can occur with open wounds. So yes, it can occur with open wounds, provided it does not extend into the affected compartment. So, what is going to be your treatment for compartment syndrome? Please do not forget this, right? It is fasciotomy, right? And an important point to be remembered in fasciotomy is you always incise the deep fascia, right? So the treatment definitely is fasciotomy, and you have to incise deep fascia. So that how do you compress, how do you decompress the compartment syndromes in the leg? So let's mention about how to decompress the superficial and the posterior compartments, and the anterior and the peroneal compartment, right? So one is that there can be a medial longitudinal incision, right, which is usually 1 to 2 centimeter posterior to the medial border of tibia, to medial border of tibia, which is going to decompress the superficial and the deep compartment, right? And then we have another lateral longitudinal incision, which is 2 centimeter lateral to the anterior tibial border, which is going to decompress the anterior and the peroneal compartments, right? So please remember, in case of a compartment syndrome, it is usually a surgical emergency where you need to decompress the compartment. We do a fasciotomy and we incise the deep fascia. Then we have two incisions: medial longitudinal incision, which is decompressing the superficial and the deep fascia, and a lateral longitudinal incision decompressing the anterior and the peroneal compartments, right? And apart from that, definitely we need to remove the splints or the tight caster dressings that may be present, and the elevation of legs, which might help in the management, right? Then there's some crush injuries which present several days after event, right? So fasciotomy in such patients can actually be dangerous, right? So it is dangerous fasciotomy over here. Why is it dangerous? Because this dead muscles produce myoglobin, right, which causes sudden release and causes myoglobin urea with glomerular blockage and renal failure. So please remember that in case of crush injuries, a late fasciotomy will not be beneficial, rather it will be harmful to the patient, causing myoglobin urea, right? So let's revise the compartment syndrome once again. So we have increased pressure, most commonly due to a fracture, which is going to be causing an increased tissue pressure, which is absolute pressure more than 30 mm of Hg, and a diastolic minus compartmental pressure of less than 30 mm of Hg, causing microperfusion, leading to irreversible muscle damage, presenting to you with pain out of proportion, pain on passive stretch, and few late signs like paralysis, paresthesia, pallor, and an extremely late sign, which is pulselessness, right? Which you clinch the diagnosis by clinically, and you do a fasciotomy. Also remember that compartment syndrome can occur in open wounds. In fasciotomy, you incise the deep fascia and you have a medial longitudinal incision decompressing the superficial and the deep compartments, and a lateral longitudinal incision decompressing the anterior and peroneal compartments. And The removal of splints and elevation of legs will help in the management of compartment syndrome. And another important point to remember is that fasciotomy is not always helpful. It is dangerous, specifically with injuries that present late. Why? Because of the risk of myoglobinuria. Right. So if you follow this sequence, no matter what clinical scenario that will be given to you, you shall be able to solve your questions of compartment syndrome. Right. So along with this, now we would discuss another very small topic, which is your crush syndrome. So in crush syndrome, we have few associations, right? So what are this association? We have association of rhabdomyolysis, definitely crush injury, and acute kidney injury. Right. So this was first actually reported in victims that were trapped during the London Blitz. Right. So it is usually seen in earthquake scenarios, mining accident survivors, and battlefield casualties. Right. So why does this crush syndrome occur? The main cause that has been attributed is the reperfusion injury, right? So the reperfusion injury is one of the major causes of your crush syndrome. So what exactly happens in crush syndrome? Let's try to understand the pathophysiology of crush syndrome, right? So we have a prolonged crushing of the muscle, right? So now this leads to reperfusion injury. Now, because of this reperfusion injury, there is going to be release of myoglobin and vasoactive mediators, right? So they release myoglobin and vasoactive mediators into your circulation, and at the same time there is sequestration of fluids, right? So the sequestration of fluid causes the reduction of the intravascular volume, right? This sequestration of fluid is going to cause reduction of intravascular volume, as a result of which what is going to happen is that there is going to be a renal vasoconstriction and ischemia, correct? And because of the myoglobin release, it will be causing your tubular obstruction, which would eventually lead to renal failure, right? So there is a prolonged crushing of the muscle, which leads to the reperfusion injury, causing the release of myoglobin vasoactive mediators into circulation and sequestration of fluids, reducing the intravascular volume, leading to renal vasoconstriction and ischemia. And the release of the myoglobin and the various vasoactive mediators is going to cause tubular obstruction and eventually leading to renal failure, right? So what would be your treatment in such cases? So the key to the treatment is your aggressive volume loading, right? So there has to be a saline infusion of around 1000 to 1500 ml, which is started until myoglobin is no longer detectable in urine, right? Then we have a mannitol administration, which is helpful, and after the flow of urine has been observed, a mannitol alkaline diuresis, where a urine output of 8 liters per day a urine output of 8 liters per day and a urinary pH of more than 6.5 is maintained, right? Now, what is the role of fasciotomy in crush syndrome? We have discussed this in compartment syndrome. If it needs to be done, it needs to be done in less than 12 hours, right? Now, post 12 hours, what happens is that there is going to be risk of myoglobin urea, right? So this is all about your crush syndrome, right? So it is basically a crush injury associated with acute kidney injury and rhabdomyolysis seen in earthquake, mining accident survivors, and battlefield casualties. The main cause being the reperfusion injury, prolonged crushing of muscles leading to reperfusion injury, which causes release of myoglobin and vasoactive mediators and sequestration of fluids, leading eventually to renal vasoconstriction and tubular obstruction. The goal or the key in the treatment is your aggressive fluid resuscitation. So you have 1000 to 1500 ml of volume saline infusion being given until myoglobin is no longer detected in urine, right? And then you have mannitol, which would help in alkaline diuresis, 8 liters per day, and a urinary pH of more than 6.5, right? And the role of fasciotomy would be less than 12 hours. Post 12 hours risk of myoglobin urea, similarly the way we had discussed in case of compartment syndrome.